Check, 88, 1, 2, 3, 4.
Good morning, everyone. I'd like to call this meeting to order at 9 a.m. A very, very warm welcome to all of you that are joining here in person and virtually. We're really honored that you are spending your Saturday morning with us. My name is Komal Bajaj. I'm the Chief Quality Officer of New York City Health and Hospitals, Jacobi NCB. I'm also the Medical Director of Sustainability for New York City Health and Hospitals. This is a reminder that the meeting is being recorded and will be posted on the AHRQ's website once it is available. Closed captioning is available for this meeting. If you need closed captioning, please click the icon at the bottom of your screen. I'm now going to take the opportunity to have everyone, all the NAC members and ex officios introduce themselves. Please say your name and your role within your organization. I'm going to start with our in-person attendees heading this direction and then going this way, and then we'll see if there's anyone who has joined us virtually. We're going to start with Mason Emmert.
Good morning, everyone. My name is Mason Emmert, and I'm the tribal epidemiologist for the Choctaw Nation of Oklahoma.
Krista Hughes.
My name is Krista Hughes, and I'm the founder and CEO of Hughes Advocacy.
Welcome. Sunil Kripalani.
Morning, I'm Sunil Kripalani. I'm a physician at Vanderbilt University Medical Center, where I serve as Director of the Center for Health Services Research and Vice President for Health System Sciences.
Welcome. Carrie Levy.
Carrie Levy. I'm at the University of Colorado, where I'm a geriatrician and palliative care physician and health services researcher.
Welcome. Jiaji Zhang.
Jiaji Zhang. I'm the Dean of the McWilliams School of Biomedical Informatics at UT Health Houston.
Glad you're here. Al Carter.
Good morning, Al Carter, the Executive Director, CEO of the National Association of Boards of Pharmacy.
Welcome. Sharon Hickman.
Good morning, Sharon Hickman. I'm president of Change Then Consulting.
Mary Beth Mockich.
Mary Beth Mockich. I am a professor at CU College of Nursing in Massachusetts Medical Campus, and I'm a health systems research scientist at a level 1 safety net hospital.
Welcome. Michael Millison.
Good morning, Michael Millison. I'm a self-employed consultant, health quality advisors, looking at quality, safety, and patient-centered care.
Welcome. Cincy Hernandez Cancio.
Hi, my name is Cincy Hernandez Cancio. I'm the Vice President for Health Justice of the National Partnership for Women and Families. And we focus on the patient and community voice in healthcare policy.
And Mario Molina.
Hi, I'm Mario Molina. I'm the chairman of the United States of Care. I sit on a couple of health system boards, and I'm a retired insurance executive.
And on the line virtually, we have NAC member Joan Gelrud.
Hi, I'm Joan Gelrud, cardiovascular clinical nurse specialist, past senior vice president for hospital and health planning quality at Kaiser Permanente and at Luminous Health.
Welcome, Joan. Now take an opportunity for our ex officio members. We have Mindy Kidder from the ONC.
Hi, good morning. I'm Mindy Kidder. I'm the Chief Nursing Officer at ONC.
Welcome. So glad that you're here. And I do not see any ex officio members in person. Did I miss anyone virtually on the line? David, I'm so sorry I missed you earlier. Good morning. David Ash, I'm a NAC member. Please introduce yourself.
I'm David Ash. I'm a Senior Vice President of the University of Pennsylvania.
Welcome, David. We had a very robust discussion day one of this NAC meeting which is happening in advance of the Academy Health Annual Research Meeting. And I have no doubt that we will have a robust discussion today as well. A few other housekeeping items. First, just our agenda for day 2. We have a few other housekeeping items, but then we're going to dive right into discussion of priority populations and maternal health. We're going to have an update on the AHRQ Patient-Centered Outcomes Research Trust Fund Extension Program. We will have the opportunity for public comment, and then we will have a reflection from the NAC on both sort of day 1 and day 2, just sort of things that are top of their mind. So as a reminder to make a chat anytime during the NAC meeting, please email your comment to the email address listed there with the subject line real-time post. As mentioned, there is an opportunity for verbal public comment during the NAC meeting. Please email the address there no later than 10 a.m. Eastern today if you would like to make comment. We ask that comments are limited to 3 minutes each. As we think about, our comments today, I have, really the belief that we're all here because we're very capable and we want healthcare to be better. And so we ask that comments remain respectful and focused to the topics at hand. If there are any, comments that don't fit into that, they will not be included into the chat. So with that said, we're going to go ahead and get started. We have a really robust, discussion ahead. I'm really honored to have 3 esteemed presenters here today. The first is Dr. Kamala Mistry, who serves as the Associate Director of the Office of Extramural Research, Education and Priority Populations within AHRQ. We have Ms. Emily Chu, who's a Senior Advisor for Women's Health and Gender Research and of Priority Populations, also in the Office of Extramural Research within AHRQ. And Dr. Carmela Roybal, who's a Senior Advisor in the Office of the Director, also within AHRQ. As a reminder, full bios are available in our meeting packet, because again, if we read their bios, that would take up all the time, and we really wanted to hear from them. So I'm going to turn the mic over first to Kamala and Emily for comments.
Great. Good morning. Can everyone hear me? So good morning. It's wonderful to be here and have the opportunity to speak with you about maternal health. And I'm going to focus on both the work that we're doing at AHRQ, and Emily's going to give you some details on that. And I also I'm going to give you kind of a big picture around the work that we're doing at HHS. So by way of an agenda, just walk through it. I've been serving as the agency lead for maternal health, so I'm going to provide an update around the HHS wide work. And then I'm going to be joined by Emily, who's going to look deeper into the work that we're doing at AHRQ and really talk about the intersection of priority populations and maternal health. And following Emily, we'll hear from Carmela Roybal. I think I said it correctly, yes, who's, as Kamal mentioned, is the Senior Advisor, and she's been working closely with Bob on our focus on American Indian and Alaskan Native populations. She's going to focus on maternal health and also talk to us about improvement initiatives. So with that, there we go. I'm just going to give a little bit of background. So these statistics will probably not be new to most, but I wanted to provide sort of a national snapshot of where we are with regard to maternal mortality in the U.S. The maternal mortality rate in the U.S. is double and triple that of other high-income countries, and even greater than many low-income countries. In 2022, 817 women died of maternal causes in the United States. Among pregnancy-related deaths, nearly 2/3 occur in the postpartum period. And you can see this in the figure that I've included here from the Commonwealth Fund report that was released recently. In the US, there's been an overall decrease in maternal mortality from 2008 through 2021. Yet, maternal mortality has been described by the World Health Organization and CDC as really the tip of the iceberg. And maternal morbidity is really the burgeoning problem, which is at the base. For every individual who dies as a result of their pregnancy, it is estimated that 20 to 30 more experience significant lifelong consequences that affect health and well-being. Thus, within HHS, there's really been a steadfast focus on, so I would say, persistent and consistent focus on really understanding severe maternal morbidities. And that's because we want to prevent morbidity, but also mortality and morbidity, but we also want to think about increasing and improving outcomes for both mothers and infants across the lifespan. So, a little more about severe maternal morbidities, as that's been a big focus both at AHRQ, but also at the HHS level. So CDC defines severe maternal morbidity as unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. I also just want to point out the impact not just to women, but also children as well. SMM has steadily increased in the US in recent years and is estimated to affect more than 50,000 mothers or birthing people annually. This data from a recent JAMA paper that was published by Dorothy Fink, who's the Director of Women's Health in the Office of the Assistant Secretary, OASH, shows advanced maternal age, C-section, and comorbidities, along with race and ethnicity, as associated with higher odds of mortality and morbidity, severe maternal morbidity. While SSM prevalence has been increasing for all patients, the data shows higher rates for racial and ethnic minority patients, and that's regardless of age. So I wanted to go back now to sort of the HHS focus. I just want to say that data that I've shared with you has really been the backdrop. Much of the work that we've been doing at the HHS level has been data driven. And that's by these analyses, but also the work that my HCUP colleagues have been doing, a lot of work around severe maternal morbidity. So a shout out to Pim and colleagues within that group who've done a great job. And I really want to focus on the work that we've done with the Office of the Secretary and the White House to coordinate and maintain sort of momentum on this across the administration. I would say much of this work started in the Trump administration and continued into the Biden administration, and it's full force. If you haven't already, I'd encourage you to look at this blueprint. It really lays out sort of a coordinated approach across HHS on maternal health. During times of flat budgets, CRs, and things like that, we've actually made the most of the funds that we have across HHS and really work to not duplicate and really work together. Across HHS, we've really continued also to monitor and evaluate this plan. It just wasn't one and done. I think we've spent a lot of time really trying to understand where we are, where we need to be. And so it's going to continue, this blueprint, to be an important part of the evaluation. We've also been putting together a dashboard, and AHRQ and Emily and many of us have been a part of that, which will really help us more in real time understand these statistics and this data and be able to think about how we can work together on the disparities. Disparities is really around postpartum deaths, and also SMM have really been a big target of the work, and you'll see that within the blueprint. But we also have been really focused on access to care, quality of care, chronic conditions, behavioral health, and the role of racism and discrimination, along with this notion of respectful care, which also Emily will talk a lot about. So AHRQ has really continued to play an important role, both in the data, as I mentioned, but also in really pushing to think about how research can translate into action. This is something Bob is very passionate about. And so I'm going to let Emily, I'll hand it over to Emily and let her talk a little bit more specifically about our contributions in that realm. Thanks, Em.
Thank you, Kamala. Hi, everyone. My name is Emily Chu, and I serve as AHRQ Senior Advisor for Women's Health and Gender Research. And I'm really excited to be here today. And thank each of you for spending your Saturday morning with us to talk about these really important topics related to maternal health. Like I mentioned, I'm really excited to be here to talk about AHRQ and our competencies and our approach and how we really unpack the maternal health work from the federal government perspective. AHRQ's competencies are related to health systems research, practice improvement, and data and analytics. And these competencies demonstrate how AHRQ aims to help healthcare systems and professionals deliver care that is high quality, safe, and of high value. Understanding that, over the next few slides, I'm going to approach our maternal health portfolio organized by those competencies. So kicking it off with health systems research, displayed on the slide, you can see many of the selected funding opportunities that we have at the agency. Many of you know that AHRQ funds a continuum of grants, research, mechanisms, cooperative agreements, and contracts in order to fulfill this health systems research competency. Related to grants, these mechanisms range from our standing RO1, which is our health services research projects, to those demonstration and dissemination grants, or R18s, to our mentored research scientist awards and the K awards, to the dissertation programs, to conference grants. But notably, I'd like to take some time to emphasize our AHRQ special emphasis notice related to advancing health equity and healthcare equity. This was a really exciting opportunity for the agency because within that notice, there's an explicit call out on maternal health and maternal health care delivery. And because of this emphasis notice that was recently released, we've actually seen a substantial uptick in the number of applications across the continuum of grants that I just mentioned, listed on the slide. So many of these grants focus on maternal health care delivery, health systems, and the way that healthcare is delivered. So this is really exciting for us, not only at the agency, but for us from the viewpoint of maternal health. And if you have any interest in learning more about our maternal grant portfolio, women's health grant portfolio, gender research, et cetera, please reach out and I'd be happy to talk to you about other projects that we funded through the various grant mechanisms that I listed on the slide. Excuse me. Moving forward now to our practice improvement competency. AHRQ approaches this work in many different ways. First off, AHRQ funds the Evidence-Based Practice Center, which fuels the Effective Healthcare Program. This program improves the quality of healthcare by providing the best available evidence across the gamut of healthcare. It's related to things like harms on drugs, devices, healthcare services, and this equips and helps healthcare professionals, patients, policymakers, and systems make evidence-based, informed healthcare decisions. Listed on this slide are just two examples out of a plethora of reports that generated by the Effective Healthcare Program. Kamala already mentioned the Respectful Maternity Care Report. I'll touch on this later in my slides as well, but that was recently released this year, as well as a final evidence review on hypertensive disorders of pregnancy. So these really do relate back to HHS high-value priority areas of understanding the role not only of respectful maternity care, but also the role of the causes of chronic comorbid conditions affecting maternal health. Again, still sticking with that practice improvement competency, I want to take some time to recognize our Patient Safety Network, or PSNet. And I'm very excited that one of our co-editors is in the audience with us today, so that's wonderful. PSNet is AHRQ's one-stop shop for all things patient safety. It features a collection of the latest news and resources on patient safety. It has innovations and toolkits, free resources, opportunities for free continuing medical education and training, which many providers know are few and far between on the web. So that's also very exciting. The platform itself provides very powerful searching and browsing capability. Users are able to really tailor the site based on their interests and needs. And as you can see, based on the homepage that I have displayed, there is a great wealth of information on PSNet. And today, I really just want to focus on two facets of that I have circled on the slide. The first are primers, and the second are WebM&M case studies. First off, primers are really intended to be short snapshots related to a patient safety issue or practice or research in the field. To give context here to primers, it's not uncommon for educators to use primers within their course curriculums to be able to teach patient safety issues in a really easy to understand, digestible way. So an example of a primer that we have on the site that was recently updated is our maternal safety primer. So that was a really great piece of literature. So please don't hesitate to check out. Moving forward now to our web M&Ms, our web morbidity and mortality cases on the web. These are cases that are submitted mostly anonymously by users, plus a corresponding commentary written by an expert in the field. And the intent for the cases and case studies is to unpack patient safety events that may occur. There's also a special designation of these case studies called spotlights, and that's where you can gain that free continuing medical education on the website. Upon my last check, I believe there were 5 or maybe even more maternal safety, women's health related web M&M case studies for users to use and to interact with. Keeping still with that practice improvement competency, I want to spend a little bit of time talking about the safety program for perinatal care. And those of you in the room from the agency know that this is my personal labor of love at the agency. There are multiple phases of the perinatal safety program for perinatal care, otherwise known as SPPC. Phase 1 and phase 2 are complete, and there are tools and outcomes related from those projects on the AHRQ website currently. AHRQ developed this program in order to improve patient safety culture of labor and delivery units and to decrease both maternal and neonatal adverse events that result from poor communication or system failures or other patient safety events. So as I mentioned, this slide depicts both the first and second phase, as well as the future of the program. Publications in the journals that I have listed on the slide have really demonstrated great promise of this program and highlighted the importance of longer-term evaluation and systems partnership, which is really what we intend to do with this third phase, which is the safety program in perinatal care, respectful maternity care, which will be conducted in partnership with both our colleagues at the Centers for Disease Control, CDC, and Health Resources and Services Administration, or HRSA. As Kamala mentioned before, the HHS focus on respectful maternity care, we conducted an evidence review through the Evidence-Based Practice Center that I briefed on related to respectful maternity care, which is serving as our foundation and strong evidence base related to this third phase. The SPPC toolkit is really unique because it leverages clinical safety protocols from HRSA's Alliance of Innovation in Maternal Care, or AIM program, and it couples AHRQ's unique expertise in teamwork and communication science and patient safety centered outcomes research on maternity care. In addition to using CDC's backbone with the perinatal quality collaboratives, that gives us the ability to work directly with the states in order to leverage the work that we're doing. So as you can see, we're working really hard internally at AHRQ to think critically of how to leverage the work of our partners across HHS and in the private sector and build on that work and to advance the science in this space. And so plans for this toolkit are currently underway. We expect to launch this program at the end of this fiscal year, which is really exciting. And we hope that this toolkit will be not only comprehensive, but bring together multiple aspects across the government to really improve maternal health and safety. So stay tuned for that one. I'm a little biased, but I'm very excited. Last up, rounding out our data and analytics competency, AHRQ, many of you already know that AHRQ has a very robust portfolio of data and analytics, most notably HCUP, or the Healthcare Cost and Utilization Project. HCUP has a plethora of resources available on the web related to maternal health, including statistical briefs, Excel tables, data visualizations that users can engage with, et cetera. There's also a series of information available in HCUP related specifically to severe maternal morbidity, which Kamala mentioned in her slides, and there's a dashboard that users can interact with on the HCUP website. Building on HCUP, I also really want to highlight another aspect of our data and analytics portfolio, which is our CAPS program, or the Consumer Assessment of Healthcare Providers and Systems. The CAPS survey is unique because it covers topics that are important to patients and in which only patients can assess, such as how they communicate with their providers, the shared decision-making that occurred during their care, and how they assess or accessed clinical healthcare services. Notably, currently, there is no CAPS instrument that exists that is specifically designed for the maternal care space. That is measuring prenatal and childbirth care from the patient's perspectives in the variety of settings where they would engage in this care. In 2023, AHRQ issued a request for information to gather broad public input on the survey design, and opportunities are underway to gain additional stakeholder feedback. So stay tuned for that one. That's going to be a really exciting opportunity for the agency as well. So while I've briefly just talked about some of our maternal health programs, I want to shift and talk about maternal health population initiatives that we have here at the agency. AHRQ's National Quality and Disparities Report, or otherwise known as the NHQDR, is a product of collaboration across many entities within HHS, as well as other federal departments and also the private sector. The NHQDR has provided an annual summary on the status of health and healthcare delivery of the United States for over 20 years, since 2003. This team prioritizes reporting data and measures that are broadly representative of the performance of our healthcare system over time. The slide displayed on the screen references an example of that type of data from the chart book. In 2020, you can tell that there were large racial and ethnic disparities in prenatal care. That was given within individuals who had a live birth in the last 12 months who received early and at least adequate prenatal care. As you can see, non-Hispanic whites accessed this care the most, and that there were significant disparities across the other races and ethnicities displayed on the slide. Most notably, non-Hispanic, American Indian, Alaska Natives were some of the worst individuals who engage in adequate prenatal care over in the last 12 months throughout their pregnancy. The work we do as a part of the NHQDR supports population health initiatives nationally. This is an example of the AHRQ data that we use to spotlight disparities for our priority populations. So keeping with that same theme, I'll turn it over now to Carmela, who will talk a little bit further about AIA and maternal health, the disparities that they face, and programs that we have targeting this population.
Thank you, Emily. Sengi Tamu, good morning. Biagindi kundawaha. Takiripo pimpoa navi hawa tampu vi anamu. My name is Carmela Roybal. I come from the village of Okeowinge, New Mexico, and I'm a health researcher, a disparities researcher, and I specialize in Indigenous populations. So today we're going to talk a lot about disparities, Indigenous peoples broadly. So we're going to include some of the data in here around Pacific Islanders, our Native Hawaiians who face extreme disparity within the context of all healthcare, but maternal health specifically. And so at any time, I am open to questions. You can stop and ask. We're going to go through a little bit of the history and the pieces that are contributing to a lot of these factors. And so I really want this to be an open discussion, and you're welcome. You're welcome to, we're going to learn a little bit about history and some of the really critical intersections that need to be discussed and put on the table for us to move these programs and initiatives forward. So thank you. And with that, we're going to talk about the American Indian and Alaska Native population in the United States. I'm just going to give this kind of background so that we can kind of look at how critical maternal care, how critical it is for us to address health disparities in a very, very intentional way. So between 70 and 100 million American Indian Indigenous populations across the North American continent. Today, we're at about 2.9%. We're about 9.7 million American Indians, Alaska Natives, Pacific Islanders here in the United States. We have seen a tremendous downsizing of the American Indian and Indigenous population over the last couple centuries. So today we have 574 federally recognized. I bring this up because the federal recognition of Indigenous people either allows them access to federal health care or keeps them or restricts them from healthcare access. And these are things we have to work around when we're thinking about Indigenous populations and how we serve them. So there are 66 state federally recognized tribes. And you're going to wonder, why are we mentioning this? The state recognized tribes are not eligible for federal health care through the Indian Health Services. So this leaves tens of thousands of people without resources around healthcare. And those are the individuals that you serve across all of the public and private institutions, okay? So the government has a federal trust responsibility. So American Indians, Alaskan Natives, within that context, are a political group, often lumped into the idea of racial and ethnic groups. But this political group have a very different relationship with the federal government. Tribal citizens are members of three sovereigns, their tribe, the US, and their state. All federally, all tribal indigenous peoples in the United States live within the state boundaries. Okay. So between 1787 and 1871, the US entered into nearly 400 treaties with tribes. The US obtained 98.9% of all tribal land base. So when we talk about health disparities and we refer to historical traumas, the reduction and removal of land and forced removal and all of these different historical, which we can talk about a little bit later, is the contributing factors to many of this. So tribal, right here, Baltimore, we had several tribes. This is their homeland. This is the Piscataway and the Susquehannock tribe. This was their homelands. So imagine all tribal nations right now reside within 36 states. So the forced removal of basically all nations. So within that, the US would respect tribal sovereignty and ensure the survival and welfare of Indian tribes and people. So that is the trust responsibility. The undisputed existence of a general trust relationship between the United States government and Indian people today. So the federal government has a special obligation to protect tribal homelands, resources, defend rights, and has a duty to fulfill this commitment, and healthcare is central to that. So now we're going to talk about the status and kind of the state and just a very broad. The life expectancy on my reservation is 45 years old. We are a tribe of 1,700. We lost 300 members during the course of the pandemic. This is a quote from Chairman Peter Lingeek of the Crow Creek Sioux Tribe in South Dakota. He also mentioned, and I want to recognize him that he may be on the line today, that they lost the majority of their language speakers. So I want to mention that every single tribal nation has their own governance structure, language, and culture. So imagine the impact that this had. The average life expectancy for American Indians and Alaska Natives in mainland, 65.2 years. That's 10 years less than the general population. And if we look at the data intersectionally, we're going to see that there's different pockets across the United States, depending on the region where this life expectancy dramatically drops, just as in Chairman Peter Lingeek's tribe. 45 years is the life expectancy. So yesterday when we were talking a lot about, healthcare, aging, many people are not worried, thinking that they will never reach the age of receiving Social Security, or that these services at 65, because we haven't addressed it through the life course. So laying this, backdrop, the healthy life expectancy for Alaska Native 62. This is actually for Native Hawaiians. Native Hawaiians, one of the authors, Ha Kapuna, mentioned how 13 of their years are in disability. So considering the life expectancy so between 2019 and 2021, life expectancy declined 6.6 years, and in our area in New Mexico, 8 years. So it's really important to look at the data in different, right? It's really important to look at intersectional data and to break the data apart, look by region and look at all of these different critical, if we're going to think through interventions or how we apply this or how do we bring resources. So laying that kind of foundation. And you can see here, and in the other data, this is the mortality rates for American Indians on the top in orange. Second highest pregnancy-related mortality. American Indians, Alaska Native are 2 times more likely to die from pregnancy-related causes. 93% of all American Indian pregnancy-related deaths were deemed preventable. In 2022, the fetal mortality rate for American Indians, about 100,000. For Native Hawaiians and Pacific Islanders, we saw that number increase to 10 per 100,000. And if we compare that to non-Hispanic white women, we see the difference here. So it just immense disparities needs to look into. Between 2020 and 2021, they reported 598 American Indian, 305 Native Hawaiian and Pacific Islander fetal deaths, totaling 903 indigenous fetal deaths between. And the reason I give you count data, because I want you to see the impact that this has on a tribal nation. And we have tribes that have as many as, 5 to 25 members, to some that are upward of over 100,000. You can imagine the detrimental impact and the generational effect that this has on these nations. Just a few more items, but one thing that I really wanted to highlight is the mental health. The 31% of the deaths related to suicide or poisoning post. They say in many areas of the United States, this is one of the only populations where the children will not outlive their parents. American Indian women are 3 times more likely to receive late or no prenatal care. They're 1.5 times more likely to be diagnosed with gestational diabetes, elevated rates of cardiovascular disease, hypertension. And there are many different ways where American Indians receive healthcare. So we have Indian Health Services, which only serves, it serves 2.2 million, but if you look at the general population, you're looking at 9.7 million. So where are the other 7? Indian Health Services isn't the only, this is an issue for everyone. This is an issue for all private, public, hospitals nationwide. So if you think about Indian Health Services, many times we think that that is the only place that people can go and receive healthcare. They only have, imagine 576 nations, and there are only 13 obstetric clinics. There are only 27 hospitals with limited services that usually provide primary care. That means all specialty services provided to Indigenous people are outside of the IHS. And only those who are eligible, who are federally recognized, are eligible for those services. So when we're thinking public, private, and state health programs, there are many reasons, and I just, a few items here. Long distances to receive care. About 50% of the population has private health insurance. Others rely or no insurance at all. About 15% have no insurance. Many of them discrimination. There's a long history of discrimination within the health system. So many structural barriers affecting Indigenous people, American Indian women. One of those items was forced sterilization of women. 25 to 50% between up until the 80s of women who attended some of these clinics were sterilized. So when you're looking at tribal downsizing, or you're looking at the erratic, of a population, this is the piece, right? And there's this long history of discrimination within those systems and the fear of accessing care through these systems. And so I provided a few pictures just to give you, because we've been doing maternal care for thousands of years. So what you're seeing here is photographs of cradle boards. So we've been doing medicine, and we've doing healthcare, and we've been for so many different traditional knowledges around birthing and the protection of individuals. And so I kind of wanted to incorporate, and we can talk more about that, how we integrate those things. So here at AHRQ, we have launched a Native American Health Improvement Initiative. So this is our way of fulfilling that trust responsibility with the tribes. We are putting together a director's series. We are forming a tribal stakeholder group where we invite leaders, health specialists, community members to come together and talk about these different critical issues. I will be leading a data work group Data is critically important to understanding the baseline of what these actual disparities and how we create interventions that are successful and sustainable. And so I think data is one of those really underlying conversations that's often, unsaid. And so we're partnering with Indian Health Services, 638 tribes. A 638 tribe is a tribe that access their health. They have complete governance over their healthcare system. So that means that a tribe, there's a basic clause where they can extract their funds from the federal government rather than running it through IHS, and then they're able to produce and build their own health center. And so we plan on supporting 638 tribes. We plan on supporting IHS with all of these different AHRQ innovations and tools. We're also partnering with urban Indian organizations that provide healthcare. We're collaborating with FQHCs, trying to get this information out, building health blogs, taking many of these resources, toolkits around maternal health and primary care and other areas so that we can get those into the hands of those that could really use this and need this. And also creating sort of a website or building out our website so that we can create pathways for research funding opportunities, training, and just creating a pool of resources where we can improve and use AHRQ's resources to improve healthcare. This is also part of an executive order where agencies need to increase accessibility, flexibility, and to be able to use these programs and these resources to enhance healthcare within their system. So thank you very much, Kundawaha. And looks like we are open for questions. So
Thank you, Carmela, and thank you to all of our presenters. The NAC yesterday met to begin to discuss some issues related to the systems and structures that are needed to address special political populations and the disparities that you very elegantly spotlighted today. The discussion in the breakouts yesterday also included how can AHRQ effectively disseminate tools, resources, and guidance who care for special populations, and also what other strategies are needed. And so I'd like to invite report outs from those groups so that we hopefully then can combine the conversation that you had today with what was said yesterday. We're going to start with Mason, then Al, then Carrie, and then David. I ask that your report outs be brief and additive. If something has already been said, please just move to what has not yet been said. Mason, the floor is yours.
Thank you. Yes, so we met yesterday to discuss these questions, and several topics that that were brought up was really IHS not being fully funded. That's a systemic issue that we're seeing where they're not having those pre-appropriated funds and able to deliver the care they need, and while also addressing the waiting period to get into urban Indian healthcare centers. Those can be difficult. We know many Native populations live within urban areas versus tribal reservation lands. So that's something we would like to see greater focus on. And then also kind of tying into what Carmela mentioned was the IHS or the federal government responsibility. That trust responsibility falls on the entire federal government, not IHS alone. So it's great to see AHRQ taking that lead. And then also taking kind of meeting people where they are. Instead of having people go to these clinics or facilities, getting them the care they need where they are, whether it be in their community, kind of what they call street medicine, taking a model from that area and seeing if AHRQ could innovate on that and really create something, to meet the needs of these populations. Another area that we talked about was kind of like a clearinghouse or area that AHRQ could create and kind of oversee where tribal nations can share innovations and models that work for them. Many tribes are able to collaborate, but with them so dispersed across the United States, what's working for one tribe might be beneficial for the other, and we can all build upon that instead of recreating the wheel. So that was something we found important and would like to kind of see what AHRQ could work on in that area. And then, of course, working with tribes on these toolkits and resources to where they can be tailorable. You know, each tribe has certain needs, and it can't be a one-size-fit-all model for all. So we found that important to mention as well. Let's see. And then in terms, you know, of course, data and research, ensuring that we observe and recognize tribal data sovereignty. You know, tribes have the right to maintain control and access of their data. And we want to ensure that the federal government, you know, maintains and respects that, but also works with them all so that we have the data we need to make these decisions and to make these resource allocations and to identify the needs of this special population. Yeah.
Thank you, Mason. Al.
Thank you, Kamal. In addition to what Mason said, we talked a lot about insurance rates. And so the uninsured rate decreased for this population from 32% to 20%. However, it's still the highest rate of uninsured. We also talked about what are best case scenarios. So we talked about the Asian population and how they have the best outcomes. How do we mimic that for the American Indian, Alaska Native? And what does great healthcare look like for them? We talked a lot about the geographic locations, look at processes that have health enterprise zones, look at integrated practices, look at select vans for medical routes and transportation challenges, and also look at healthier food options. And there was a lot of focus with our group about community health hubs and how can we wrap in other services. There was, going back to the insurance coverage, it was stated that many don't consider IHS to represent insurance for the American Indian, Alaska Native. And so when we look at appropriations for IHS, it isn't the same as like appropriations for VA. And so how do we look at a better approach for funding? We also talked about needing to pull in the community for these recommendations and collaboration, and how there is, you know, different cultural concordance beliefs. And so what the framework should be moving forward should be based on data and evidence. And that data that we look at should have a cultural competence component to it. Very focused on evidence-based, but determining flexibility of systems designed to meet the middle of address this and really understand the importance, basic requirements, because that cultural knowledge, the structural knowledge is a lot different. And so coming to them and to this population instead of just trying to stand something up without any type of integration.
Thank you, Al. Carrie.
So our group talked about the need to improve trustworthiness and to really rely on the community to provide guidance as opposed to, you know, just coming in with ideas about what we think will help. So identifying community needs, doing an environmental scan, looking at what's working and trying to build upon those areas. One example that was given in terms of barriers was that Medicaid was looking at, or there were some enrollments in Medicaid for these individuals, but because the Indian Health Services were funding them, there was this tension because the state didn't want to absorb costs that the Indian Health Service should be absorbing. So I think understanding some of those nuances and where unnecessary barriers are getting in the way of funding for healthcare. Heightening the awareness. I mean, I think all of us were surprised by much of what you presented and hadn't seen that before, and being sure, you know, often it's in this group that is combined and we don't see the nuances within that group. And so being sure that that awareness is front and center. In terms of the building on the community health hubs, really a reliance on community health workers who are the embedded, trusted souls within each of the communities to help with messaging, to help those who are trying to improve the system know how to do that well and in a culturally responsive way. AHRQ, of course, we just heard about the various opportunities for funding, but really emphasizing funding for this population, and especially among those who are embedded in this population. We talked about considerations that are important in terms of maternal health with the focus on mental health, as we just heard, and that half of pregnancies are unintended. So the care needs to be much upstream of when the pregnancy actually occurs. We talked a lot about medical trends and how that might get in the way or help. Amazon now has $49 televisits. Could that be helpful? Could that be harmful? Not sure. But just trying to get services to those who need them, and also on recognition that 80% of individuals are in urban areas. And so we talked a lot about rural communities, but a lot of these folks are in urban areas. And so how do we serve them most effectively? And then finally, with measurement, really looking at the measurements that can be counterproductive. And we talked about cesarean rates, for example, and there's penalties if you have a higher cesarean rate, but in many cases they might be needed. And so how do we make sure that people are getting the care that they need and we're not responding to measures in a way that was unintended? And then finally, the tools, you mentioned some fantastic tools already. Some that were mentioned that I thought were innovative is just mom and baby co-visits. Often the baby has to go to the pediatrician, mom has to go to the GYN, but that's a lot of visits for somebody who's, managing a new baby. So could we do co-visits, just testing some of these models, looking at good algorithms from AI, for example, that can let us know when a mom needs escalation of care and do that well in advance of a crisis occurring. And I'll stop there.
Thank you, Karen. I'm going to give our panelists an opportunity to respond to what they've heard in a moment. We're going to finalize the last report with David.
Great. Well, we had a very spirited discussion echoing many of the comments that I've already heard. We did start from a position of not false humility, but genuine humility, that we were not really necessarily the right ones to address these questions. And growing from that, we pretty much followed the format of the 4 questions that we were asked. And in view of that sense of, as I said, humility, we thought we might fall back on generic strategies that have already been mentioned for trusted and meaningful engagement, asking people what they need, inviting them to lead the design of the future state as typical starting points. Well, in terms of the second question about whether there were specific initiatives AHRQ can learn from, we thought that HRSA has some experience in this area, and also the Canadian government's A Fair Future for Indigenous People might offer insights. But none of us was close enough to that work to know whether there were genuine insights there that would be useful in this setting. For the third question about how AHRQ can effectively disseminate the tools, resources, and guidance to care providers and systems serving American Indian patients and their families, we actually took issue with the last phrase of that. We think that really implementation, science can offer some best practices about representation and autonomy, but it's worth noting that, frankly, no organization does a really terrific job of getting their tools, resources, and guidance adopted or turned into useful change. This represents often the final common pathway for effective change, and it's a hard one. And we probably need new tools for that. And so in response to the fourth question about should AHRQ adopt a different dissemination and implementation approach, the responses are more generic and not necessarily reflecting what one might do for this particular population. Many of us, I think, have long taken for granted the idea that organizations like AHRQ are trusted entities. But we have more recently, I think many of us had our eyes open to the recognition that many people don't trust the scientific enterprise, don't trust government agencies, and confuse fact and fiction. AHRQ or any of these organizations really can't achieve any of their missions unless they invest in credibility and improving the trust relationships that they have with the groups that they most want to serve. And that is a challenge for all organizations, and probably one that it's worth it for AHRQ to invest in specifically, explicitly, and with purpose. And then finally, we concluded with the idea that traditional dissemination strategies often assume that behavior change can come from disseminating information in the form of education. And, but frankly, we probably need more strategies. What is the equivalent of putting fluoride in the water? That doesn't really require education. What is the fluoride in the water equivalent for organizations like AHRQ? And that could include engagement with electronic health record organizations and the like that can put dissemination practices, sort of mainline them into the nervous system of healthcare and the journey that clinicians and patients take. And so there may be approaches other than the dissemination of information that may be far more effective for AHRQ to use, not just for this population, but generically. And I'll pause there.
Thank you, David. Would love to hear each panelist's reaction to some of what they've heard, and then we'll open it up to comments after that.
Thank you all for just very thoughtful feedback and answers to these provocative and difficult questions. I think I just want to, my broad reaction is really around, I think, our struggle to think about these disparities and really think about the work that we have in maternal health, and the research has really been focused broadly. And much of the work hasn't really thought about the context the way that Carmela has described. There hasn't been that link or that ability to sort of, even among the tools that we have and the resources that we have, there's a disconnect. Those have not been tested and really thought through from a sort of user-centered design, or thinking about stakeholder needs, really including participatory methods in that work. And so I think we are at sort of a disadvantage. And I think really hearing from you makes me realize that I think it's not just about disseminating the tools, but it's really thinking about building new and relevant tools and really using important implementation science grounded work to think about those different contexts, and thinking about the questions that we need to answer specifically around the unique perspectives, the unique contexts. I think many people mentioned the urban versus the rural. I think another aspect of that is really around the insurance issues, Medicaid, where does that fit in? You would think that broadly it would fit in a bigger way. And I think I was equally surprised, I think, as many of you, that it hasn't sort of done that. And where are those sort of discrepancies or those clashes between systems and policies that we, I think, at AHRQ can uniquely sort of help and look at. So I think, we do have a sort of way to think about this from more of a systematic way or through a framework and trying to kind of break down these different pieces. But I think we have a lot of work to do. So, and with that, maybe I'll hand it over to Emily.
Sure. Thanks, Kamala. I think that each of these really thought-provoking comments made me reassure that our work now related to maternal health and our portfolio at the agency is grounded not only in health and healthcare equity, but in respectful maternity care. And so for those of you that may not be familiar with respectful maternity care, that is care that is culturally competent, it is clinically informed care, and it accounts for structures of systemic racism in healthcare in the United States. And so by building our tools on that platform and really using respectful maternity care as the foundation, we're hoping to be able to, move the needle on some of these disparities across the gamut in healthcare, especially related to maternal health care. I mean, there's a lot of work to be done here, but I'm really excited that at the agency, this is really one of the first times that we're taking this approach to really center culturally competent health and healthcare equity focused care. And I'll turn it over to you, Carmela.
Thank you. So thank you everyone for all of your wonderful and really thoughtful comments. And listening to them, thinking life course. We need a maternal life course perspective where we're building healthy bodies through the life course. When we're looking at our population, we know that there's a very high, extremely high rate of cardiovascular disease or at a very young age. So when you start looking through, cultural differences in ages and birthing and all of the different nuances, we realize that a new and we need to start addressing earlier on in life and really thinking how do we really upstream, right? Upstream is Carrie. We need to kind of go back and kind of really assess what we're laying the foundation for and really hone in on some of these other prevention and building healthy bodies as we kind of move through the right prevention. And when we think of, so IHS is not health insurance. It's not health insurance. It's a health system. And what happens is that there's often conflict and around veteran services. So you'll see that many of our nation's veterans are turned away from services. No, you get service from IHS. No, you get services from here. So there's this going back and forth, and you'll hear many people like talk about all of the different conflict because of insurance and the inability to receive services in the midst of medical emergencies because of this insurance entanglement with all of these different who pays what. And so and the other thing that's really important to note thinking through is that IHS provides primary care. And most of these FQH, it's primary care. So all specialty services run through all of the other, right? So when we're talking about like systemic issues and we're talking about American Indian communities crossing the border from their reservation into cities to receive specialty care. This is where a lot of these pieces are falling apart and where we see a lot of the discrimination. If we, it's publicly noted in many, much of the literature, all of the different like systemic issues and barriers and walls and the turning away and so that contributes to a lot of this. So maternal and many other forms of care that are. So I just thank you, data. Thank you so much, Mason, for bringing up data and data sovereignty and the importance that it is for tribes to have access to their healthcare data, to make informed decisions about what their tribe needs and how they can protect or implement or support their health. So that's something that is really, really important. And also for us to take note as an agency, what is data sovereignty? And what is it when we're dealing with nations? So each of these tribes are their own nation. They're nations within states, but they have that same responsibility with the federal government. That's why we call it nation to nation. So it's really important that we respect their sovereign right to own their data. So private health insurance, the same thing. So I do hear a lot in with some of our, tribal leadership who struggle to obtain critical health information in order to address the needs of their population. And we saw this during COVID. And so there's lots of examples through history, but we're at a point where we can make change and where we could sit down and really work through some of these to create different pathways and educate and heighten the awareness around these different pieces. Where is it broken down? So thank you so much. Kundawa.
Kamala.
Yeah, I just want to add, I'm thinking about this, looking over at Bob too, in terms of, dissemination and implementation, certainly, and thinking about it, how do we also, there's certainly gaps in research. We're a research agency. And so how do we think about also the mechanisms we have, the way we do our work, since I'm part of the extramural research group? I mean, how do we think about that? Even, the data issues and things, many of the policies even embedded within the grants and the way that we do our work are not necessarily favorable or make that easy. And so, we've been looking at our portfolios and we've actually been looking at minority serving institutions. We've been looking at, other populations, AIN, and who are applying for grants, who are doing this work. And so I think there's a need to really think on that level as well, given, our role as a research agency. So.
Thank you for that. I want to spotlight, there was a real-time comment from member of the public, Richard Ullman. And Carmela, you touched on this, so I'd love for you to react to this. The comment is many Native Americans have served in the US military. How is AHRQ working with the Veterans Health Administration to improve care? You mentioned some of the challenges, maybe also reflect on some potential opportunities.
Can you say this question again?
Yeah, the comment was many Native Americans have served in the US military. How is AHRQ working with the Veterans Health Administration to improve care for Native American veterans?
And so when you're looking at the data and you're thinking about our nation's American Indian veterans, we overrepresent any other racial and ethnic population in the US military. That is a tradition. We also, American Indian, Native American women have the highest, enrolled members in our US military. And I could, speak for different states, and you can go back and look at different data, but it is a tradition. And so it's really critical and important that we honor that. And what's happening, working on the ground and meeting with lots of our veterans, how much they struggle and how little and how the trouble that they actually face, sometimes having, they're not able to get services from veteran services. They're turned away because they're considered their tribal status says IHS. And so you'll hear different, people talk about their experiences because there is this lack of communication and understanding about who's responsible for their care once they become enrolled in our military. And so that is part of our trust responsibility to address the healthcare needs of every veteran in this country and American Indian, highlighting. And I know that there are some really great programs within the veteran, with the VA and others that are really trying to address some of these gaps in healthcare and trying to make, areas culturally competent, I want to say, but there's a lot of work to be done there to really think. So systems thinking, how do we reconnect these systems so that we can address it?
Thank you very much for that. I would invite folks to start to raise their hands. We already have one hand raised, but I just want to spotlight. I just Googled CDC maternal mortality and see a report from the National Center for Health Statistics, which outlines maternal mortality rates in the US in 2022. And what I want to spotlight is that the bar graph includes Asian, Black, white, non-Hispanic, and Hispanic. And so some of the statistics that we saw discussed today are not to be found in this report. They're probably rolled into one of those categories. I just want to sort of bring that up as a potential opportunity. I'm now going to turn it to comments from our NAC. And I first want to start with Cincy Hernandez-Cancio.
Hi, first of all, I want to thank the presenters for this presentation and especially recognize AHRQ for spotlighting and spending so much effort and resources to elevate this issue. I come here as a, professional health policy, health equity, expert, but I also come here as a woman who barely made it out alive of birthing. And I'm like just one of literally tens of thousands of women in this country for whom it was like almost an act of God that we actually are still here. And I don't need to get into details of my story, but I was sent home with preeclampsia. I was sent home septic. I was fired by an OB because I wanted him to coordinate with another specialist. All of these things are happening in our nation's capital, in a teaching hospital. And at the time I had Cadillac insurance. So I just want all of us to understand that this isn't a problem that's over there somewhere else or over there where the poor people are or over there where the brown people are. It's happening everywhere. In the case. One of the, in my organization, we work specifically on maternal health care, and we actually have a survey out right now called Listening to Mothers, a survey that's been out for 20 years. That's in the field at the moment. And I just want to underscore how challenging it was to get funders to pay for oversampling of Indigenous populations. And so, and I wanted to get oversampling of Puerto Ricans because our rates look a lot more like Black rates and the rest of Latinos. I could not get nobody to pay for that, right? You know, some of the folks here heard me try to get help to do that. So one of the things that AHRQ can do is really look at how they model putting the resources into the field that need to be there to be able to address the health of specific populations, especially in maternal health. And yesterday there was a really good conversation about like, you know, more programs that are more community-based participatory research, making sure that we have pipelines and ways to get individuals from the communities involved in the research and build capacity in that way as well. One of the most terrible things that I see is that there's an enormous chasm between the people who actually know what's happening, the people who actually know what's needed to solve the problem, and the people who have the power and the resources and the bully pulpit to be able to make it happen. And I think that AHRQ is positioned in a way that could really push in a different direction to try to break down some of that or lessen some of that chasm. Very, you know, when we're talking about behavior change, the behavior that needs to change is not that of the individual or the family or the community that's under all this stress and under all this under-resourcing. It's the behavior of the systems that not only aren't addressing them, but created those inequities to begin with. The last thing I want to say is about another area where I think AHRQ could have a lot of impact. So I don't know if y'all noticed that over the last 10 years, there's been such an elevation of the story of the Black maternal health crisis. That didn't happen by accident. That happened because there were foundations and other entities that started really directing resources to not only look at the data, but look at the stories and wrap it in narrative that was compelling. And I think that and it's frustrated me just as an outsider, the invisibility of the Native American community not getting the same kind of, people don't know about it. And so I think that AHRQ in particular could do a really good job in pushing more of this kind of awareness and understanding, not just of the statistics, which again, our statistics for these populations, they're very small and challenging to get the statistics that everybody would want to see, but the story. So that is, thank you so much for the work that you do, and that's it. Thank you.
I'm going to give the panelists a moment to react to that, but since you mentioned something that I wanted to spotlight again. You asked about, or you mentioned, populations know what's happening, they know what's needed, and they know what matters. As we talked about consumer experience yesterday, we spent a bit of time talking about surveys, and also recognize the importance of patient-reported outcome measures, especially as we're, as mentioned, how do we deliver culturally appropriate care? Part of that is knowing what matters and measuring what matters to the populations we serve. Panelists, any reactions to Cincy's comments?
I'll just start. I think that there has been, so I just want to spotlight a little bit the issue around data. I think, Kamal, what you pulled up, this is something that I think at the HHS level, we've talked a lot about, and really thinking about not just quantitative data, but qualitative data both, and really thinking about how do we allow the qualitative data to think about the nuances, but also do a better and more robust job of being able to think about gaps in data, particularly around the AI-AN population. Mm-hmm. There are a lot of small footnotes on all of those things that you've read on the CDC website, sort of under that explain why things are being collapsed. We've done a lot of work on how we define race at the HHS level, broadly at the government level. And so we're talking a lot about, how to do this work better and make sure that we're not collapsing things, The other piece of that, though, is trust. I think really what Carmela was mentioning around, the sovereignty of data, the idea, I think we really need to understand and think about whether qualitative data, quantitative data, how do we really embed the ideas around trust? And then even in the work that we do at AHRQ, if we're funding research, how do we sort of implicitly build that into the mechanism and realize that that is sort of the foundation of good research and good work. And we have to leave time for that. I think we have to think about what are the ways. We recently put out an RFA that was around racial ethnic disparities and trying to think about equity. And we did sort of embed the ideas around CVPR and really thinking about it. But I think there's a lot of work to be done across multiple layers and really understanding if we want that work to be done thoughtfully and correctly, and then sort of build up to, data and think about, interventions and tools. I think there's a number of things we can consider from the mechanisms perspective as well as other ways. So.
I think over 30 years ago, AHRQ partnered with IHS to conduct the Cyan, so a survey of American Indian household. And so that data is there, but we have a format, we have a template. And a part of that survey was conducted in traditional languages. So a percentage in English and we had a lot more language speakers 30 years ago than what we have today. But I think with technology and the way that we can actually access and create, using different techniques to collect data, I think we can collect mixed methods, quantitative and qualitative, in a very different and very honest and a very private way that I think would be very respectful. And, thinking through these types of like critical partnerships, rebuilding or relaunching something like the Cyan, where we can go in and talk about issues even outside of healthcare, missing and murdered Indigenous women.
Yeah.
Children and men and the impact and all of these, but we can get to a lot of these questions that could I really support. How does CMS reimburse for America? What are the differences and nuances? Why is this affecting? Why do not people, where is the access? How some tribes drive 300 miles to get healthcare. They need to cross.
Yeah.
And if you look at the population that lives in the urban city, they're driving back to the reservation to get healthcare. So the way that we access care is completely different. So we think we're in the city where no, people are forced to go back to the reservations to get care. We also know that the Indian Health Service is not at capacity. They're lacking many, many medical doctors and providers. Very difficult. It's very difficult to run a system when you have, so there's so many different nuances that could be taken into consideration in collecting that data. What's the experience? What's the lived experience? And what is the lay expertise among tribal populations? And that expertise, how are they managing? So a lot of expert managers out there because of all of the different challenges. We have a lot to learn from the population.
Thank you, Carmela. Oh, Kamala, do you have a?
No, I just worry a little bit because there's, I know many of you have heard of the CDC Hear Her campaign. And so there's many national campaigns that are out there. And I think we're sort of missing, thinking about the nuances here. And while I think those campaigns have been tested or thought through for many populations, I do think the AIAN population often is, I think there's it's invisible. And I think the voices, I think that's part of it. But I also think that, in many meetings, I would say there's, the numbers. It's not the denominator. It's, it's difficult. I think this is difficult work. And I think that's true. But I think we really need to think about that. And we also need to think about how some of these tools, they may not be applicable. They may not work. And they maybe even can, make disparities worse or not, and make trust issues worse. So I think we just need to think about that too in the work that we're doing.
Thank you. I recognize that we have about 11 minutes left and I want to make sure we get to comments. We're going to go with Mason, Michael, and then Mary Beth. But before we do that, I just also want to spotlight, AHRQ has an initiative around diagnostic excellence, which really sort of widens the aperture and thinks about the journey long before, ideally long before someone has a health condition, but when they have it, how do they enter? Carmela, you mentioned someone driving 300 miles. And so, I think diagnostic excellence across the journey of care is really understudied, especially in maternal health. And I would be, just sort of put it out there to sort of think about how do those sort of efforts merge. We're going to go with Mason.
Thank you. Well, first, I want to say, I'm very appreciative to see all the work that AHRQ is doing to address these, concerns and disparities across the Native American population. Something that has been brought up is culturally competent care, and I would like to see, not just from AHRQ, but on the federal government, government-wide, kind of an understanding of how underserved these populations are by people who are Native American. In the United States, the last statistic I saw is that 0.3% of physicians identify as Native American. That is insanely low compared to all other races. And these populations, especially Native Americans, feel more comfortable receiving care by those who are Native American within their tribes or within their tribal healthcare system. So, whether that be, researching the impact that, of tribal residencies, of medical schools with a focus on tribal healthcare. We see those coming up across the United States now in a real effort to increase the amount of Native Americans in healthcare. So now we are starting to get there where we can start researching that a bit more. Another area I'd like to mention too is the social determinants of health. A big area that's been discussed is prenatal care. What are these social determinants? Can we research how to, how they're all multifaceted and kind of combining to cause these disparities? Telehealth has been brought up, which is amazing, but when you don't have internet access, you can't access any of those resources. And many on the NAC have heard me say, where I'm from, a town of 400, we got DSL internet when I was about 9 years old. And that's been the only option until this past November when we had satellite internet installed. So, before it was comparable to dial-up. So, really accessing these telehealth services could be a game changer, especially when it comes to behavioral health and those crisis situations, but we have to have the infrastructure in place to do so. I appreciate all that AHRQ is doing because it is so important, but, these areas of research are important to focus on and kind of, realize it's going to take a full hands approach across governments, tribal, state, federal, local, to ensure that we're meeting the needs of these populations and kind of addressing what's exacerbated the maternal health care crisis in tribal communities.
Thank you, Mason. We'll get a few more comments out and then have the panelists react. Michael, then Mary Beth.
So I want to echo the thanks to AHRQ for everything they've done. And I love what Cincy said about storytelling. I have a lot of connections to the patient safety community, and I honestly do not recall, first of all, anything to do with the Native American community. And secondly, not so much on maternal mortality. And I was thinking about that. And to be honest, there's a disproportionate number of women who are active in the patient safety community. And if you have personally been killed, you're not going to be active in the patient safety community. That also affects the CAP surveys, by the way, but that's an entirely different matter. So I would suggest that, for instance, World Patient Safety Day is coming up and in September, and there's work being done in DC with Patients for Patient Safety Movement Foundation, that are connect on both maternal and certainly on the Native American communities. There are activists, for instance, there's a large American Indian community in Chicago. There's patient safety people that there needs to be some of the activists to reach out. Leapfrog does maternity things, but do they do some of the mortality? Can Leapfrog do more? Should the Indian Health Service be pressured to be part of the leapfrog group, right? Can you do something on transparency? Can you bring into some of the participatory medicine things that have to do with technology, internet kind of things, social determinants of health? There are a lot of activist things from some extraordinary patient activists, truly, that I'm in awe of, and not just, isolated things here and there. And AHRQ and your communities, I think, could benefit from connecting with them. The Patients for Patient Safety has something called Project Pivot. They have a grant from Gordon and Betty Moore Foundation. I think they're working with AHRQ and a bunch of other people, but they're looking at just starting to look at patient-reported experience measures, patient-reported outcome measures, right? I'm part of the group and all the rest of that. But again, how can you bring in some of the Native American communities and some of the other communities with that? So there are a lot of activities that I think can be connected in a larger way. Certainly, I know VA and military are active in these groups. I've never seen anything from the Native American community. And lastly, if you'll permit me a bit of humor, many years ago as a journalist, I did one story about the American Indian community. I went to the Devil's Lake Sioux tribe because the Sioux Indians at Devil's Lake were making camouflage for the U.S. cavalry. And it was a fun client of theirs. So there actually turns out, I just looked it up, they're the most successful manufacturing plant for anybody out there. But I appreciate everything you all have said. And, I encourage you to lift up a little bit from some of where you're focused like this and connect to the broader community.
Thank you, Michael. Mary Beth.
I'm sorry.
No worries. Thank you. And this has been an amazing read and a lot. I've learned a lot. So thank you for that. In terms of systems and structures, I think we may have an opportunity from AHRQ to provide data, if you will, to increase the number of midwives. So the president's report talked about the importance of midwives and the effectiveness in their care. But yet there's a lot of barriers and structures to how midwives can be educated across state lines. It's very hard for schools to get students from across state lines because of various legal barriers, if you will, in terms of schools not allowing students from Arizona, for example, to come to Colorado for a midwifery program. So I think getting data to help us increase the volume of midwives to be educated to provide that care. And to your point, Mason, when you talked about the importance of having Native American programs for physicians, it would be lovely if there were also Native American programs that actually embraced nurse midwives as well to help provide that care to our populations.
Thank you, Mary Beth. Sunil.
Thank you. One of the things that really stuck with me from our small group discussion yesterday, which I wanted to bring forward, is the incredible diversity in the Native American community, not only in terms of language and geography, but size of tribes and inherent resources. One other approach I would recommend thinking about is how to build capacity further, particularly among the smaller tribes. It's so important, of course, to garner external resources. But in parallel to that, is there a potential for a learning collaborative of the smaller tribes that may be able to share approaches, share resources, and the idea of creating a database or repository of successful tools, approaches, educational programs that tribes can share with each other could be part of such a learning collaborative. AHRQ has done this in many other contexts, and I think would be well suited to lead such an effort.
Thank you, Sunil. We've got about 5 minutes remaining. And so what I'd like to do is turn to the panelists, ask for any additional reactions or reflections on what you've heard over the last few comments. And then for those that were here yesterday, a question was posed on if you had a magic wand, what would be sort of your first target? And so I'd like to go sort of, really think about maybe starting with Emily, any sort of additional reactions, reflections, and then, or maybe if not a magic wand, what is one thing that you want to make sure now people sort of leave here with?
Thanks so much. I a couple of reflections first while I iterate over this magic wand question. Mason and Mary Beth, you touched on some points that really resonated with me. And, current research has really indicated, there's a discussion about discordant, concordant medical care and, underlying the importance of nurse midwives, particularly in Black maternal health, the Black maternal health crisis in the United States. And really from the provider's perspective, the impact of, or I'm sorry, from the patient's perspective, the impact of having a provider that looks like me should not be discounted. And so your point about nurse midwives really resonates with me. And in some of the maternal health programs that we're planning, midwives, midwifery associations, et cetera, have a fundamental seat at the table because they provide care that we know really is supportive to patients in maternal care. In response to the magic wand, this probably won't surprise those that have heard my talking points today, but I think that really underscoring and centering the importance, if I had to walk away with something and continue to work on, would be this health equity, respectful maternity care aspect is really being the ground for all of our research, not just a add-on, not just something, okay, we considered this after we already designed the program, but really the beginning of the program, the start. And that's something that we go back to and say, okay, are our patients' voices heard? Are we all culturally competent? Are we providing care that isn't exclusionary but participatory? Are there patients on the ground that are planning this, that are helping with the foundation? So that would be the big takeaway for me to continue to press this charge. That way we can make sure that we're developing programs and projects that are meeting the needs of the end users and eliminating disparities. Your turn, Kamala.
I think I'm going to also, I think Mason, you mentioned, a whole government approach, and I think that that's also going to be important. I mean, this was, part of a president's executive order, this focus. And I think as I'm sitting on many sort of broad HHS committees, I think one thing that often happens around AIN is excuses or passing the buck sort of, or that's IHS. And I think Carmela has done an incredible job of telling us what IHS does and doesn't do. And so I think that, I've been really pleased and excited about the work that we've done, the cross-government efforts around maternal mortality, particularly around HHS. And I think there's an opportunity here to sort of think about the work we can do around AIN broadly, of course, in terms of maternal health, but many of you have named other issues as well within the population that we could be thinking about. And I think we need to embed that in our conversations and figure out, maybe AHRQ can, really figure out how we can partner with our other agencies and make sure that that continues to be, sort of at the forefront of the work that we're doing across HHS. See you.
So thank you. Thank you so much. I think about magic wand, and I think I do have a magic wand. I never think if, because just being able to sit here and highlight a population that has the potential, that the medicine carriers that have led this continent force, and we're here talking about one of the most critical junctures, like an existential crisis. And so this is putting this out and getting the conversation going. This is, I look forward to all that we can move and partner and get in contact with our local communities to, move this agenda and think through all of these different pieces. This is wonderful. And if I did have a pot of gold, I'd definitely invest in data. We need a new baseline, and we need to redefine what we talk as far as when we talk about American Indian, we talk about Indigenous, we talk about Native Hawaiians, Pacific Islanders who have disparities, our Puerto Rican communities, all of our Caribbean, who have all of these different disparities that are just kind of a shadow pandemic, and bringing this to the forefront. So grateful. Thank you all very, very much.
Thank you. What a poignant note to end on. Please join me in thanking all the panelists for being here today. So we're now going to move to our next session. I'd like to invite our speaker, Dr. Tess Miller, to join us. In the meantime, I'd like to also acknowledge that Dr. Sherry Ling, our ex officio from CMS, is here. Welcome. We're so glad that you're here. I also want to highlight that in our agenda, it noted that we were going to vote to finalize the report of the subcommittee on the National Action Alliance to advance patient and workforce safety. We have had discussions at prior NACs about that important report. In order to give some of our new NAC members additional time to review it, we're going to defer that vote to a later time. So with that said, it is my absolute pleasure to invite Dr. Tess Miller to join us to provide an update on AHRQ's Patient-Centered Outcomes Research Trust Fund Extension Program. Welcome.
Thank you very much. I am delighted to be here this morning and to give an update on AHRQ's Healthcare Extension Service Initiative. I do want to start with a reminder, since our notices of funding opportunity are not publicly accessible yet, they have not been published. I am limited to how much detail I can talk about. So I may not be able to answer your questions, but nevertheless, please ask them. It may give us things to think about as we continue to move forward. Oops. Wanted to give just a reminder, background, some rationale for the project. You may, many of you have heard this before, but this project is going to be in direct support of AHRQ's mission and its competencies. It also will support and address AHRQ's PCOR Trust Fund strategic plans, mission, vision, goals, and objectives. And I think, more importantly, we are leveraging all our expertise in supporting healthcare systems and healthcare delivery transformation and really borrowing on what we've learned from prior investments. Lastly, it will, really move forward our work, I think, in very important ways in those areas. I couldn't have asked for a better setup yesterday from the discussions, in that one of the main objectives is, when we started thinking about that, is how do we get new evidence or a body of evidence into clinical practice faster? And it really is a focus, and we've thought a lot about both the facilitators to doing that as well as the barriers to doing that. We also, of course, have looked a lot at the variation both across states, across healthcare systems, with among providers, among populations. And so really, how do we try to start addressing the variation in care at a system, local, and even population level? So and lastly, of course, we are looking at those barriers, both in terms of policy, in terms of payment and incentive, in terms of actual practice processes, so transformation and workforce. And I just want to highlight one thing. Dr. Valdez talks a lot about actionable knowledge. So we're not talking about trying to get results from one study into practice. We really are trying to talk about where we have a body of knowledge, where there have been some maybe pilots, where there are tools and resources that we can really start to scale and spread. There are two overarching goals for the Healthcare Extension Service. One, clearly, is accelerating the dissemination and implementation of patient-centered outcomes research evidence into practice. And as I mentioned, that really is looking at healthcare improvements in policy, payment, and practice. And the second is to reduce healthcare disparities among Medicaid beneficiaries, people who are uninsured, and people who are medically underserved. We, on June 6th, put out a notice of information, and I think the important update in this notice was that really three components to AHRQ's Healthcare Extension Service. Those are the state-based healthcare cooperatives, which I have mentioned in the past, but I'll tell you a little bit more detail about today. But then we also intend to have a national coordinating center and a national evaluation center. So as I mentioned, there really are three component parts, and really at the heart of this are the state-based cooperatives. And in the notice of information, you may have noticed that we provided a little bit more detail about the specific activities that we think the cooperatives will undertake. And so those include engaging with key stakeholders, including Medicaid agencies, managed care organizations, and other organizations that address the needs of people who are medically underserved, in identifying and addressing barriers and facilitators to implementing evidence-based interventions. And again, we're looking for evidence-based interventions as well as implementation strategies and where we may have tools and resources to help out. They're also going to work with healthcare policy, payment, community, care delivery, and research organizations that serve people who are medically served, and really to help build their capacity to implement patient-centered healthcare delivery improvements. They're going to conduct a multi-level initiative, so we're hoping it will have elements at the state level, system level, local provider level, patient level, but a multi-level initiative that will be focused on behavioral health. They're going to conduct evaluations, both of their model, how they set up and run their cooperative, but also of their local project and its results. And lastly, they're going to provide the support structure and ensure that these activities are integrated and aligned. So we are going to support them with a National Coordinating Center. And the National Coordinating Center is really designed to focus on four main support services, if you will. They will provide technical assistance to the recipients of the state-based cooperatives. They will establish and support learning networks, and they will also work in communications. So we've heard a lot about telling the story. So we really want someone to help the recipients of these state-based cooperatives tell us what they're learning, tell us how they're doing it, tell their story. And lastly, we think it's very important that we learn as much as possible about how to do this, how states are doing this. So we are going to be funding a National Evaluation Center, and that center will develop data, measures, and methods to assess the range, reach, and effectiveness of the healthcare extension service models supported and implemented by the cooperatives. And they're also going to conduct a multi-mixed method rapid cycle formative and summative evaluation, so across all the different cooperatives. We are asking too, I said rapid cycle, so really in all the evaluation, we are looking for methods that the cooperatives can find out as they go and adapt as they go, both how is their cooperative working as well as how is the initiative going. So I've kind of focused on these, but I really wanted to call attention to some of the key features. So we are anticipating awarding up to 15 state-based health cooperatives. We're hoping to have one in each HHS region. Each cooperative will focus on a single state. I think that's based on our experience that so much of what happens is at the state level and depends on state regulation. So that's why we've chosen to do that. We will be focusing on the safety net, as I mentioned, and there are elements, and we're trying to build off the agricultural extension service as well as a learning health system. We're trying to allow the states, the cooperatives, as much flexibility as possible to build the cooperative and focus how they work to reflect the unique situation of their state. And lastly, as I mentioned, behavioral health will be the initial target, and we're allowing a pretty broad definition of behavioral health. So we do anticipate that all three notices of funding opportunity will be published this summer. We will be hosting technical assistance calls as soon as those are out in the street to help recipients have a better understanding of what we're looking for. We do have web pages already on our website about the Extension Service Project, but we're planning on posting a lot of resources there to try to help applicants, again, understand what we're looking for, but then adapt that to their unique situation. We will be conducting targeted outreach with selected stakeholders to make sure they're aware of the opportunity, as well as so that they can help their membership. And at any time, anyone can submit a question about the Healthcare Extension Service to AHRQ at that email address. And that is already up and running. So if you have questions that I can't address at the moment, please send them in when we can. We'll be creating a frequently asked questions list that will be updated periodically. So we'll be sure to include those. So last, I'd like to I'm showing here the current writing team, which includes staff from all 3 centers at AHRQ, as well as the Office of Extramural Research, Education and Priority Populations. But I also want to say this has been so many people have been involved in this project across. So I want to thank staff from the Office of the Director, the Office of Extramural Research, Education Priority Populations, the Office of Communications as well, and Grants Management. It really has just been a cross-AHRQ effort. So thank you very much. And I will try to address any questions that I can today. Also, I'm going to take my magic wand prerogative now. My magic wand is that I come back in the future, not too distant future, and I am talking about 15 amazing projects that we have started and that we can really start talking about some details. How could we improve these? What resources do you all have that we could bring to bear to help these states? So again, thank you very much.
Thank you, Tess, for that wonderful overview, and to AHRQ for that this cross-cutting effort. I invite members to begin to raise their hands, and I want to spotlight that Joan Gelrud, who's joining us virtually, has a question. Can the state-based health extension services include public health? Post-COVID opportunities were identified. Resources for evidence-based care transformation is a great asset for health departments of the country, too.
And the very simple answer is yes.
Thank you. I'd like to first start with Carrie Levy.
Just a simple question. When you talk about safety net, is there a specific definition or is it more broadly defined?
It's more broadly defined. We will have one in each of the notices of funding opportunity, but again, we are hoping to be relatively broad so that we can reflect the unique needs in each state.
Thank you. Mason, then Jaji.
Thank you. I think this is an excellent program. It's something that's much needed. I would encourage you to consider possibly whether this round or in the future, requiring a component of either, both like a tribal or rural consultation for these states that opt in. More often than not, these rural communities or tribal communities are kind of left out of these conversations when they're facing really the brunt end of this crisis, especially behavioral health. So in a lot of states will defer and say, well, these patients receive care from their tribal facilities or IHS, but it's going to take, again, that all hands approach to where we work collaboratively to identify what's working best in these areas. So I would encourage you to consider a requirement where these recipients do have to consult with rural either entities, facilities, and tribal. Thank you.
Thank you so much. And I will certainly take that back to the team to see if, we can enhance what we are putting in the notices.
Thank you. Jaji.
Just a question here. What is the requirement for a state to be part of this? Does the state government have to be involved, or is just the organization proposed by healthcare providers, systems, or researchers to do this? And a follow-up question is that if a state involvement is required, does the state without Medicaid extension qualify?
Unfortunately, that's a little bit more detail than I can tell you right now. Certainly, we have thought about all of those things, and I think tried to find a place where we will be able to get a lot of good meritorious applications. So again, trying to allow for flexibility, but I can't answer very specifically right now.
Thank you. Again, I encourage folks to raise their hands. One comment that I will make, and again, sort of framing this as a healthcare leader within a municipal health system, It is wonderful when we see programs like this underway, and you mentioned that there will be technical sort of assistance, just recognizing that, different entities are at very different places when it comes to sort of their machinery and ability to engage in this. Mason mentioned, tribal communities. And so just acknowledging that, I hope that as part of this, there is sort of additional attention placed on sort of that component with the technical assistance.
We appreciate that. And we have had a lot of discussion about that in terms of having a mix of where people are in development and what we might have to provide as technical assistance.
That's wonderful. I'm also just scanning. Cincy, thank you.
I just wanted to add on to the comment earlier about how to define safety net. One type of provider from a health equity perspective that's very important, but that often gets overlooked are like the small community-based providers. Like back in the day when my dad was a primary care physician in Springfield, Massachusetts, he was the only Puerto Rican doctor in a place with 30,000 Puerto Ricans. And normally, and of course, what we know, that is their safety net. People would drive from other states just to be able to have that cultural competence. So making sure that the definition can include those kinds of providers that are really important, especially in terms of having a history of being trustworthy with their community.
Thank you. Thank you very much for that comment.
In line with the conversation that we've had over the last few days and the, thoughtfulness of community participation, hoping that there's a sort of structural way in which that is encouraged through the application process onwards. All right. If there are no further comments, I know we have a public comment. Please join me in thanking Dr. Tess Miller for being here. Thank you very much. I'm reminded now that we have 2 public comments. And so just as a reminder, public comments are limited to 3 minutes each. We'll go ahead and begin with our first one. I will, give you a sort of a sign when 3 minutes is over. I'd like to welcome Chairman Peter Lengreek, who's joining us from Crow Creek Sioux Tribe from South Dakota. Chairman, the mic is yours. If you are speaking, we cannot hear you. Okay, so our next comment is in person. Is that right? All right, wonderful. So we'll check back in with the chairman to see maybe if he comes back on. But in the meantime, I'd like to invite our in-person comment to join us. And if you could introduce yourself, please.
Hello, thank you for having this today. My name is Janice Tefty and I'm an engaged patient partner. I know Mike Mullins and then a lot of the safety people, and I know a lot of Native Americans. So I'm from Seattle, Washington. I live a few blocks from the Urban Indian Health Institute and saw a lot of horrid things happen within our community during COVID. If you remember, they were sent body bags and instead of, assistance for COVID tests. And I just want to say that there's something, I really appreciate what you're mentioning about reaching out to the community, because I think that the United States has fallen behind and has not met the needs of the Native American population. Anybody that knows rurally that the community centers run out of money by the time, before the year runs out. So they never have enough money. And also I recently came across the last couple of years, the American Indian Public Health Resource Center, take that name down, AIPHRC, and that's in North Dakota. And a friend now of mine, Ryan Eagle, he goes out into different states and is teaching, or different nations, and is teaching them around issues around research, how to do research themselves. So we do have actually community members. One is a PCORI ambassador, Alma McCormick. There are people that could reach out to other individuals. So I think that's very important. And in the extension service, I just want to say I'm very engaged and I'm aware of a lot the federal government has to offer, but I was not aware of the extension service, even though I have lived rurally and worked on farms, until I was at the primary care, North American Primary Care Research Group just a couple weeks ago. And so also wasn't aware that they have a tribal extension service. So I think that's somebody else that you could reach out to. So I don't know how much power you have in advocating for the communities, but there are some very rich health services like what they've been able to achieve in Alaska and a few other places. So I just want to say that this is a population that has been very underserved for many years and historically harmed. And that's one of the reasons you can't just walk into their community. It takes years to work, be friends with them, be neighbors. Thank you.
Thank you. I'd now like to welcome Chairman Peter Lengeek for your comment. And as a reminder, comments are limited to 3 minutes. Chairman, the floor is yours. You're on mute in case you're speaking. We cannot hear you.
Hello. Everybody hear me? I'm having terrible connection. I had to log back in twice already.
Chairman, we're glad you persisted. We can hear you.
Okay, thank you. I'm very honored to be a part of this morning, and coming into this as a newly joining member of this advisory committee. I just really want to appreciate the efforts everybody has put forth. Some of the things you've been talking about, we are engaged here in South Dakota. I became chairman when the virus hit, and the virus hit 4 days later after I became, took this leadership seat. And one of the first things I did was I reached out to the state Department of Health, and I kept them very close to me through all of this. They were very instrumental, and we became very close in a professional relationship in a state that has terrible race relations between the Indians and the non-Indians. But for my people, I had to create that relationship and maintain it, and it was very beneficial to us, despite the losses and the things that we're dealing with today, such as severe mental health, addiction, PTSD, anxiety, depression, homelessness, all these things that we're dealing with now after the pandemic. I still keep the state very close to me. And we are now working together to create a summit in September that is going to be called Integrating Indigenous Health. We worked very closely. The state was very interested because on this reservation during the height of the pandemic, when we were losing people every day, I really pushed traditional medicines and things, indigenous plants that grow here that my ancestors used for sicknesses and epidemics and pandemics that they experienced back then. And the state became very interested in how we were doing that, because we were doing it with great effectiveness and great success. We were getting people off of ventilators and out of the hospitals with indigenous medicine. But I couldn't have done that without the help of the state. And so I don't know if South Dakota is part of the states that you guys have chosen to work with, but hopefully it is, because I think it could be a model for the rest of the states that are going to experience this again. As we all know, a pandemic, it's not a question of if, but a question of when. In these days, with the environment the way it is, the earth the way it is, and public health the way it is, we're really setting ourselves up for another disastrous pandemic. So I just want to commend you all for holding this today, and this group for all the efforts, and I'm really looking forward to working with you in the near future. Thank you.
Thank you very much, Chairman, for your comments. So our public comment is now over. We've had so much robust discussion over the last few days, and I'd like to invite our NAC members for an opportunity to reflect and spotlight things that, are top of mind for them. I'm going to start with Mario and make my way down there. But you know what, before we do, some people may know that I every meeting sort of have a haiku. I don't know why that sort of is a way that I tend to reflect on things. And so I'll start by sharing mine as a way of, maybe getting the juices flowing. So my haiku for today is listen and include all patients for improvement, real collaboration. And so as we think about sort of the journey that we've been on for the last 2 days, right? We began by talking, or we have talked about specific populations like the aging population and the important initiatives that need to be placed sort of across the lifespan. We've talked today about American Indian and Native Alaskan populations, and the importance of listening to people through consumer experience. There were a lot of really interesting insights shared about consumer engagement. And I would encourage us to think also more deeply, not just on surveys, but about patient-reported measures and how those two efforts synergize each other. We heard about mechanisms like the extension program that will help bring some of those magic wand ideas to a reality. And then for me, all of this is wrapped in the clear importance of health services research and the critical role that AHRQ and all the friends of AHRQ play in really thinking about, moving from not just what is learned to what is implemented. And so those are some of the ideas that are top of mind for me. Mari, I'm going to turn the mic to you, and then we're going to go down the line.
Thank you, Kamal. It has been really enlightening for me to hear about these issues on aging, on the Native Alaskan and the American Indian populations, and also what we can do to better listen to people about what they need from their healthcare system. The one thing I would like to see more of is more public comment. I'm disappointed that we're not getting more public comment. This is a great opportunity and forum for the public to bring your issues to AHRQ. And I would just hope that more people and more organizations would take advantage of that in the future.
Hi. First of all, I want to start with a lot of gratitude. I've been on this NAC maybe about a year. Mush this together. And this has been, I think, the one that has had the most overlap with not only the work that my organization does, but where my heart and passion and kind of ikigai is. I echo what Mario was just saying about the lack, more public comment. One of the things is like, unless you're in this space, you don't even know what AHRQ is. And so earlier comments, I think, by the director and others about how do we message better what this entity does and the value it can have kind of to your real life experience that you and your family members may have in the future trying to get healthcare is really needed, especially where it's like, this is kind of where the rubber hits the road, right? Where the best thinking and research to the extent that it's, we have it, gets implemented. And so I really encourage more thought and strategy around, and for political reasons as well, right? Like, we don't all know what the House just did, right? But also for public awareness so that it can really we can be a lot more responsive to what individuals and families and communities need.
Thank you. Michael.
I think all of us are a self-selected group that are going to express our appreciation for AHRQ and wish that what the agency is doing, its good works, had more resonance. There's an old Jewish saying that says, from your mouth to God's ears. lacking divine intervention on behalf of AHRQ, which, certainly is possible, I think that it's important for all of us to figure out how to help the core ideas of dissemination of evidence needs to be accelerated to, in fact, permeate. I started writing about what became evidence-based medicine 30 years ago. And it was very difficult for me to wrap my mind around the idea that things had appeared in the medical literature and doctors didn't actually do them. And now it's difficult for me to wrap my mind around the idea that things have appeared in the medical literature for decades and doctors don't actually do them. And for the lay public, there's this border between trust and distrust. And I think that AHRQ, with the positive way it does things and things we've heard today, needs to be a powerful force for emphasizing what we were told by Aaron Carroll, which is HSR saves lives. And it is very difficult to dramatize that because there are no ambulance sirens coming into the ER. And having done that for a number of years, that's kind of our challenge, I think, as an advisory group, to help with our communities to tell the stories that will help people understand why what they are doing and many of you all are doing are saving lives. And so I'm grateful to be able to be a small part of telling the story.
Thank you, Michael. Mary Beth.
Yeah, thank you. Indeed, it has been an amazing day and a half. I think when I reflect on the day and yesterday and the reading, the thing that resonates most with me is the fact that, our theme for this 35 years is today's research, tomorrow's healthcare. And so I really think that the way in which AHRQ garners data, gets data, synthesizes it, puts the evidence together, and then disseminates it is so incredibly powerful. But to some of what my colleagues had said, it's not always well understood. And so, or even available, if you will, to non-healthcare providers. So the opportunity to disseminate what we do more widely to the public that we serve, as well as the healthcare clinicians that we all are a part of, I think is an incredible opportunity, because the resources that we produce and the evidence to support health are so vast and so well put together. I think we just have a larger opportunity beyond speaking amongst ourselves, if you will, as clinicians. And then I think that the importance of the power of narrative really can't be understated.
Thank you. Sharon.
This has just been a very enlightening 2 days for me. I learned so much that it's a reminder there's a lot I don't know, which I really appreciate. As an improvement specialist, I really appreciate the conversation about pulling in the people that design what we're doing to be a part of that solution. And I think whatever we disseminate needs to be very easy for people to implement and for them to understand, and learning collaboratives on how they can learn from each other as they're learning what they're implementing and going back and understanding what worked and what didn't work. I think that that's very important. So I echo everything everyone has said. Mario, I agree with you. I think it would be wonderful if we could have more public comment, because that's what this is about.
Thank you, Sharon. We're going to go to Al, and then I will go to Joan, who's joining virtually, just to give her a little heads up. She'll be after Al. Go ahead now.
First, Kamal, thank you. You've done a wonderful job chairing this meeting, so kudos to you for that. Second, I agree with my colleagues here. I specifically thought, as what Cynthia was saying earlier about the access and how do we get more involvement. If you're not in this space, you don't know about what AHRQ does and the capabilities. And me being a pharmacist and just being appointed to this board, to this committee last year, and now being eyes wide open on the capabilities, we're sitting on gold here. The data, and Dr. Carroll said it yesterday, access and use of data to improve patient health is key. And we have a huge opportunity. Talking about the American Indian and the Alaska Native, my eyes are wide open to that. And what I'm left thinking now is, what other areas are there that we can uncover with the data that we have, and how can we look at that moving forward and bringing more public, more individuals into this space? And I have some thoughts and ideas because we do it with the FDA, DEA, and others in the pharmacy profession. But we're sitting on gold, and we have to share it.
Thank you, Al. Gold indeed. Joan.
Thank you. So I think this meeting embodied everything that AHRQ is about and what AHRQ should be doing, from lifting the needs of underserved populations to talking about modernization of consumer experience. And I just have one sidebar on that. I believe in healthcare, we have a secret sauce that we don't touch. And that is, we know what's going to happen to everybody before it happens. We know how they're going to feel. We know what they're going to need. And if we just got in front of that and explained it as we took care of people, I think it would make a very big difference. But moving evidence to practice is one of the most important things we could be doing. We've heard about that through several other people's comments. And I hope the extensions, I really pray that the state-based extensions will help for us to do that, and for folks to be able to take advantage of the resources and the data. And I break my head sometimes to think how else we could be spreading what the opportunities are for people to turn to AHRQ and its resources. And in my fantasy, based on how much people know about what we're doing, there would be a lineup for public comment that goes longer than the meeting. Thank you.
Thank you very much, Joan. Shaji.
I cannot stop talking about AI. Okay, let me summarize my points, reiterate a few points I made. So we are at the very beginning of one of the three fundamental economic transformations in the entire human history. About 10,000 years ago, we transitioned from hunting and food gathering to farming of crops and livestock. It is a biological revolution because of the problem of food. 200 years ago, it's the Industrial Revolution that liberated people from physical labor by engines, electricity, all of this. So today's AI revolution is liberating people from cognitive labor. It's going to diminish a lot of cognitive cost, a lot of things we do. So AHRQ has a unique advantage of using this because we are more organized, more focused. We have things from everywhere. I think AI can do a lot of things for AHRQ. So my recommendation is AHRQ should have a chief AI officer.
Thank you, Jaji. Harry.
I volunteer a job.
And he's volunteering. So this is my first in-person meeting, and it's just what a treat, and share the gratitude that's been expressed for being able to learn so much and be with such caring people. I've been impressed by the vision that AHRQ's had. A couple of projects were mentioned that were 30 years ago, community-based participatory research, that type of thing, that are now becoming mainstream, but they had that vision long ago. So I think that's an important piece to be mindful of. I think it was yesterday, Aaron mentioned that there's a savings, massive savings for one more year of active life. And this mention of life course is very exciting to me. There's a book out called Outlive that a lot of people are interested in right now that talks about medicine 3.0. So 2.0 is what we're in now, where we're kind of reacting. Medicine 3.0 is where we're proactive and trying to prevent the issues we talked about with maternal health and just lifespan in general, which also builds into the American Indian and Native Alaskan work we just spoke of. So I think the themes are very exciting. The acceleration of research is clearly a place that AHRQ's putting emphasis and will be important. I'm seeing in my world that there's lots of, qualitative research methods that are rapid now, and we're getting faster, and that's critically important. And then the other part that I think is two other things. One is the public-private partnerships. I was really surprised to hear, if I heard it correctly, that half of Academy Health are not from academic centers, which is really shocking. And so I think that public-private partnership is very important. Working with venture capitalists, that type of thing, to accelerate these ideas will be important. And then the last thing is really, I come from a lens of nursing homes and regulatory oversight and the burdens that creates. And, we talk about mainlining these new interventions, but I think, which I think is critically important, because if we just keep adding and adding and adding, we can't do more. People are kind of operating at their max. I see it on the primary care side. I see it in the nursing home side. And so I would just, I guess my recommendation would be for a lens towards eliminating low value care and substituting it with high value care. I'll stop there.
This is also my first in-person meeting as an AHRQ member. And I've been so impressed to hear how AHRQ is tackling such critical issues in today's healthcare in terms of patient outcomes and healthcare delivery. As someone who's been involved with AHRQ in other ways for many years, having developed some toolkits and served in a study section capacity, I've always only seen little bits of AHRQ's contributions at any one moment. But yesterday and today really gave me a much broader perspective on just the potential for tremendous impact that AHRQ has, and it's always been there, by approaching these huge problems in healthcare delivery, priority populations, and continuing to innovate, whether it's around consumer experience or in shifting its longstanding focus in digital healthcare, towards AI. As we look at how to maximize that impact, I have one last reflection, which is that much of the work to date seems to be about developing reports and toolkits for dissemination. But as we heard earlier today, disseminating evidence is not enough. I'm so glad to see more programs focused on implementing evidence into practice, and hope that AHRQ continues to extend those efforts, particularly in partnerships with other federal agencies, but also with the communities that AHRQ has prioritized in serving. It's going to continue to be critical to engage the inputs of those communities for adapting the evidence to serve the local needs in a way that's truly collaborative. So I was glad to hear about many programs moving that direction yesterday and today, and hope that direction continues.
Thank you, Sunil. Krista.
So I want to thank AHRQ for always listening and letting us have a voice at the table and all that you are doing. Unfortunately, I missed the meeting yesterday and the robust conversation, and I hate I missed it, but I did do my homework and I read the slides. And from all the presentations from yesterday and today, I feel like all of them had a common denominator to me. And that was still, there's just not the patient's voice that's truly at the table. I believe that if the patient's voice is not part of the co-design and sitting there with the researchers, healthcare is never going to change. For example, Saturday, I had a personal medical issue, not this Saturday, last Saturday, an issue. My dad had one, and I had a client die at 6:47 this morning due to a preventable medical error. I was speaking to Kamal. Where are we to report these outcomes and our experiences? Where my voice going to be heard in all this? And until we have a voice, you're going to continue to have patients that die from preventable medical errors. And I would like AHRQ, I'll use Jaji, y'all need a chief patient voice role of AHRQ that I would be glad to be part of, because that's what AHRQ could do, is make our voice part of the research, because it's not going to change until we are. with experiences or outcomes.
Thank you, Krista. Mason.
Thank you, Kamal. I'll echo what many of my colleagues said. You know, it's been a great day and a half of meetings, very insightful, especially being my first in-person NAC meeting with you all. You know, one of my key takeaways that I've taken over the day and a half is that the patient experience matters tremendously, you know, not only in their outcomes, but how they view the healthcare system in the United States, you know, how their outcomes, how their provider treats them, and that experience differs so greatly across various areas, patient populations, and the services they receive. So I think it's great to see AHRQ, you know, creating these tools and dispersing it to where that they can share these experiences, and it's not falling on deaf ears or you know, administrations of a facility that's simply using it for quality, you know, internal quality needs. I'm very appreciative to see AHRQ recognizing these priority populations, such as the Native Americans and Alaskan Natives. More often than not, they're kind of omitted from the data, or they're not mentioned in other agencies. And I think the vast data that AHRQ has gathered and continues to gather, along with the tools that they're putting out, really positions them well to, you know, break down these silos across the federal government within these different health agencies, you know, working collaboratively to improve the patient care experience and improving the health outcomes of the populations that are having these issues. So thank you all.
Thank you, Mason. Which wonderful reflections. Thank you. Bob, I'd like to invite you for any comments.
Thanks very much. And thank you to the NAC for making the effort to join us and to share your insights and suggestions. I want to also thank the wonderful staff I have at AHRQ, truly professionals that I am humbled to have been asked to lead, because they took on a charge when I was asked to take on this agency of, I said, let's think about what 24th century healthcare needs to look like for everybody today. And they've taken that charge on, and you're hearing some of the results of that effort to try to do what AHRQ is set up to do, which is the applied science to answer the questions that clinicians and healthcare leaders, the people who organize and deliver and make decisions about how and what services are available to communities get provided. Unfortunately, you also heard about the fact that we're trying to regain our history of health services research in an applied research setting, because it's been captured by the academic enterprise. And I'm trying as hard as I can to move us back to our origins, which is to answer the questions that our healthcare leaders and clinicians need to have answered today. I'm really proud of the work that our agency staff has been doing. They've been going full tilt pretty much since I've arrived, and I have to really say thank you for that. With regard to public comment, you'll may have noticed, some of you who are new probably don't know, but we've had more public comment than the 2 years that we've been having this National Advisory Council that we had over the last 2 decades, in large part because public comment was exactly what we were trying to gain. We've now, people who are involved watching us online, they can submit comments, as you could see, and those were transferred to our chair and shared with us. But we also had public comment period. We clearly are not doing enough yet. And I agree with you completely. How we can get that word out that we clearly need to hear from the voice of patients, the voice of consumers, to make our work more relevant to them and to their communities is clearly part of the role of this National Advisory Council meetings, which our next meeting is in November, and I hope that we can generate more comment. Now I'd like to wave my magic wand and actually
say that maybe I can get my friends at Disney to do what they did for NIH. And that is, did any of you see the Disney movie called The Secret of NIM? Well, it's a great little cartoon that brought NIH to the public through children's programming and through the cartoon, but it also brought the magic of science and what science could do to improve our society and our world.
Thank you very much, Dr. Valdez, for those comments. And, you know, I wanted to take a moment to also thank you for your leadership and all the AHRQ staff, not just for putting together was an amazing last day and a half, but for the hard work that you're doing each and every day. So I'm wondering if you could join me in applause for them. You know, Al, I appreciate your comment and everyone's warm wishes about sort of acting chair, but a meeting is only as good as the people who are here and the thoughts and the comments. And as we look across this room and we have so many engaged faces and we see so many engaged members of the public who have joined virtually as well, I'm very heartened and hope that community continues to grow. I want to thank all the speakers over the last day and a half for the generosity of their time and thought. And a huge thank you to all of you for participating in this meeting. As Bob mentioned, our next NAC meeting will be held on November 20th. We hope that you will join and that you will ask your friends to join. So with that said, I'm going to ask for a motion to adjourn this meeting. So I'm going to thank you, Michael. We're going to defer the vote on the report to another time. But thank you. Appreciate that situational awareness. So with that said, I'm going to ask for a motion to adjourn. Michael, was that your motion to adjourn? That was. Thank you, Michael. And may I have a second? Mary Beth, thank you very much, everyone. Bye-bye. All right, done. Nicely done, folks.